Good morning, dear colleagues. My name is Shesov. I'm the director of Valery Gerig Department of Anesthesiology and Reanimatology in Chisinau Republic of Moldova, and it's my great pleasure to be an invited speaker to this important forum. I would like to use this opportunity to thank the Professor Tkachenko for inviting me to this event. I work, as I mentioned before, in Valery Gerig Department of Anesthesia and Intensive Care, that is a part of Georgi Paladi Chisinau Clinical Hospital. We have a huge workload of obstetric workload in our hospital. So every fourth child in the country actually is born here in this hospital. I do not have any conflicts of interest to declare related to this topic. Let's begin. If you look into the data, then you can see that neurological complications in obstetric patients are a huge problem and a very frequent phenomenon, even if there are a lot of improvement initiatives in this regard. So these are graphics from UK, the National Audit Program, and if in 2019, about 13% of all maternal deaths in UK were due to neurological complications. 4 years later, the number didn't change too much because still 9% of all maternal deaths were related to neurological complications. And actually, neurological conditions is the third most common cause of indirect deaths, and it stays for 1.23 deaths for 100,000 of pregnancies in UK, and that's a lot. We have to think about how we can improve actually these numbers because they are even more frightful at the global scale. Just look at the numbers that are provided by WHO and WFSA. So we really know that up to 15% of all maternal deaths are related to pregnancy-associated stroke. And actually up to 50% of all these stroke survivors will have a serious neurological deficit for the rest of their life. Preeclampsia, by the way, is responsible for 46 maternal deaths in 1 year and almost 500,000 of neonatal or fetal deaths. So these numbers are really frightful, and we need really to take action in order to improve the care that we can provide for pregnant ladies. And please don't forget that even our interventions, our help that we give to pregnant ladies in the form of Neurological anesthesia, analgesia, is not absolutely free of risks, and up to 1 in 300,000 ladies will develop a serious neurological complication after neuraxial anesthesia or analgesia techniques. If we look into the roots of this issue, then there are 3 main group of factors that can contribute to the development of neurological complications in peripartum period. The essence of pathogenic mechanism is relying on these 3 conditions because high estrogen levels stimulate the production of coagulation factors and increase the thromboembolic risk in pregnant women. And not only this, because normal pregnancy is characterized by high concentration of coagulation factors like factor 7, factor 8, factor 10, von Willebrand factor, and fibrinogen as well. And in the same time, there is a low concentration of pyruvate protein. So all these actually lead to a higher risk of thrombogenic processes that can take in the body of a pregnant woman. At the same time, the increase of plasma and the blood volume are contributing factors to the increase of pressure, of blood pressure, and development of hypertension. And increase of progesterone concentration in the late pregnancy tends to increase venous wall distension and the risk of small vessel arterial bleeding. And in the postpartum period as well, there is a drop in high estrogen levels, and the alteration that of estrogen and progesterone levels can change can dramatically change the brain electrical activity, and this will influence definitely the cerebral blood circulation, causing seizure, causing transient and permanent cerebral ischemia. And don't forget about pre-existing factors, pre-existing disease, age, and race of the pregnant women. Generally speaking, we can divide all perinatal neurological complications in obstetric patients in three main groups, like pre-existing chronic neurological diseases, diseases with onset or exacerbation, deterioration during pregnancy, and pregnancy-induced diseases. And here, of course, we cannot forget about preeclampsia and eclampsia. Let's go a little bit deeper in some of these complications. Definitely speaking, definitely speaking, we can say that neurological procedures are quite neuroaxial interventions for anesthesia and analgesia reasons are quite safe. However, patients sometimes develop palsies in postpartum period, and usually these palsies that are present in postpartum patients are related to obstetric origin, and we have to take this in mind and to bear this with us when we are going to deal with a pregnant woman. Because pressure and counting during the delivery on nerves and on the nerves can really affect the nerve integrity and can really lead to the lesion of lumbosacral roots of peripheral nerves, and that is quite important. Most commonly, the obstetric palsy is related to femoral neuropathy, or that can actually be not only unilateral but bilateral. But besides femoral neuropathy, there can be obturator nerve involved, sciatic nerve involved, common perineal and lumbosacral plexus. All of this can be involved. If we talk about specifically femoral dysfunction, that may result in issues related to hip flexion and decreased lateral reflex and the sensory loss in the distribution of the femoral nerve. The neuropathy of obturator nerve causes weakness in the hip abduction and internal rotation, and actually decrease the sensation of the inner part of the thigh. And if a patient has, for example, a bilateral femoral nerve, you can really be confused with an epidural issue or issue related to spinal anesthesia. So you have to be really attentive and really understand what is going wrong with your patient. Because generally speaking, if we will educate our patients and we will assess them appropriately in prepartum period, it really can lead to avoidance of these palsies, obstetrical palsies that can last for 6 or even 8 weeks postpartum. Sensory changes sensory changes related to the epidural analgesia actually can lead and can contribute at the same time to the development of obstetric palsies, because the lady simply will not be able to understand and to realize that the pressure on her belly is too much, or that external flexions of the hips is too much. So we have to inform her about this, and we have to inform her that she should avoid this extreme pressure and extreme external flexion of the hips. And at the same time, we have to instruct her to avoid to lie in the same position for long period of times, especially if she has before the delivery, if she has some sort of back pain, because it is considered to be a risk factor for development of nerve palsies in postpartum period. And don't forget about padding. We have to pad all the surfaces in order to protect the peripheral nerve from being damaged. Well, of course, we cannot say that only palsies due to obstetric reasons can develop in postpartum period. Of course, nerve injury, spinal cord trauma, Cauda-Equina syndrome, vascular injury, epidural hematoma, neurotoxicity, chemical neurotoxicity. These are well-described terms and pathologies in handbooks of anesthesia, and we have never the right to forget about it. And whenever there are some neurological changes, reducing Glasgow Coma Scale score, changes in pupillar reflexes or peripheral reflexes, or weakness of the limb or dumbness of the limb, we have to think about the possibility of nerve injury if there was a neuroaxial block in place. If the patient developed a palsy or a peripheral nerve lesion, so we have to really assess her very carefully, because the type of the mechanism of damage to the nerves can vary very much, from some demyelinization around the Ranvier nodes up to full nerve lesion. And we need to really understand what is the nature of these sensory changes or mobility changes. And for that sake, we have to use imaging radiological techniques to evaluate the patient. We have to use electromyography. We have to use nerve conduction studies in order to really understand what is the problem. Because if it's just a small demyelinization around Ranvier nodes, then the patient will come back to absolutely normal function in 6 to 8 weeks. But if there is a nerve lesion, complete nerve lesion, then the patient needs to go to the surgery as fast as possible, because good results can be achieved in first 12 hours. Good result for treatment can be achieved in first 12 hours after the lesion. Let's move forward. And whenever we talk about the neurological complication or in obstetric patients, of course, we cannot skip the topic of preeclampsia and eclampsia. Whenever there is a gestational age of more than 20 weeks, proteinuria, hypertension, we are already in a state to think about, in position to think about preeclampsia. And if there are tonic-clonic seizure activity or coma, then of course this is the case when we have to talk about eclampsia. The problem is that in many cases of eclampsia, there is no hypertension and no proteinuria, and it's sometimes quite difficult to set up the diagnosis. Studies shows actually that 1/3 of eclampsia cases occur suddenly without any pre-existing signs and symptoms, and these cases are really complicated and challenging to diagnose. In most of cases, in 83% of cases of eclampsia, there of course will be some prodromal symptoms before seizures, and this really can help us to get ready, or at least there will be a history of preeclampsia. Well, 90% of preeclampsia, of course, will occur after the 28th week of gestation, but 1/3 of them will happen after the delivery. So delivery does not mean that patient is already out of any possible risk situations. What we can do to mitigate the development of preeclampsia and eclampsia? Actually, not too much. Low doses of aspirin, calcium supplementation in the endemic zones where there is a calcium deficit, And of course, we have to think about BP, blood pressure optimization, control of chronic hypertension, maybe the use of prophylactic heparin in case of patients with confirmed thrombophilia. And if there is already preeclampsia, we have to give magnesium sulfate prophylaxis and to try to do our best in order to keep under the control the level of blood pressure. In terms of eclampsia, there is not too much new. We have to prevent it by using magnesium sulfate, and we have to give a loading dose, and sometimes there is plates for a second loading dose of magnesium if the seizure continues. And of course, if there is no effect from loading dose and second loading dose of magnesium, then we have to think about the benzodiazepines to be administered to the patient in order to stop the seizure, the seizure. And of course, in order to definitely treat preeclampsia or eclampsia, we have to start to think about the delivery, because the delivery of placenta is the key for the success in these cases. Well, other interesting but actually devastating neurological complications, conditions that can appear in our patients are cerebral venous sinus thrombosis that has an incidence of 9.1 per 100,000 of pregnancies. And this is very uncommon cause of stroke actually in general population, but females are more affected than males. And this is gender-related pathogenesis, especially significant in pregnancy period and postpartum due to hormone disbalances. Reversible cerebral vasoconstriction syndrome is a state that is due to arterial vasoconstriction and dilatation, and it is most commonly reported from week 1 to week 3, but it can happen to take place up to week 6 after the normal delivery otherwise. And usually it happens in the case of uncomplicated pregnancies. And again, the female hormone disbalance is considered to be the fact that it play a crucial role in the development of this syndrome. Posterior reversible encephalopathy syndrome is a neurotoxic state. And in this case, subcortical vasogenic edema occurs with the brain, resulting in neurological sequels, long-term sequels, and it can produce seizures, encephalopathy, headache, visual impairments, and so on. Intraparenchymal and subarachnoid hematomas are quite actually rare complication, but very devastating. And the general incidence is about 7.6 per 1,000 of pregnancy. And if you take notice about all these complications, what they have in common is the symptoms. And all of these complications can be associated with thunderclap headache, with focal neurological deficit, visual disturbances, altered mental status, and new onset of seizures. And because of that, in the diagnostic algorithm, it's quite important to do LACT or MRI scan in order to have a definitive, accurate, and correct diagnosis for all of these states. So whenever a patient has developed a seizure and she has a history of epilepsy, we have to think about the adjustment of therapy, of anti-epileptic therapy. But if the gestational age is more than 20 weeks and there is increased blood pressure, proteinuria, and edema, then most of cases it will be preeclampsia and eclampsia. Or if there are specific changes in the lab results, it can also be a HELLP syndrome, or HELLP syndrome can come as a complication of preeclampsia. But if not, then please consider PRESS syndrome. Please consider reversible reversible cerebral vasoconstriction syndrome as well. If the patient has an acute neurological deficit, it doesn't matter if it's sensory or muscular, then we need again to rely on MRI, on CT exam in order to understand if it's a case of ischemic stroke or maybe a case of hemorrhagic stroke. And whenever a patient has an acute thunderclap headache, then again, you need to focus on imaging technologies in order to rule out a subarachnoid hemorrhage or a RCVC or a PRESS or RCVC syndrome. So very difficult to do a differential diagnosis just based on clinical symptoms without a good radiologist on board. And that's not all actually, because beside all neurological complications that we talked so far, we have to mention and some very specific and very difficult to diagnose states like functional neurological disorders. Functional neurological disorders actually are associated with seizures, are associated with motor and sensory deficit, is also associated with deficit of speech and sensation. And what is very important that this pathology actually does not relate specifically to obstetrics, but due to risk factors like female gender, childbirthing age, emotional neglect, sexual and physical abuse, fatigue, anxiety, uh, is very often diagnosed, especially in during the pregnancy and in postpartum period. It's a disease that stays somewhere at the border of neurology and psychiatry. And here you have data from a very interesting study that actually observed a series of patients with functional neurological disorders, and authors were able to identify several phenotypes of this disease, like seizure phenotype, motor weakness phenotype, movement disorders phenotype, speech disorders, and amnesia and visceral symptoms. And other very important thing is that almost 1/3 of all patients develop these functional neurological disorders in postpartum period. Very important. Other important thing is that in the cases when this disease develops at the beginning of the pregnancy, it can really easily can be confused with epilepsy, and this can be an issue because if you will try to treat FND with anti-epileptic drugs, you will only will expose the patient and her fetus to risk of teratogeny, but but there will be no positive gain for this future mother, because in most of cases they need the support of psychologists. They need the support of group therapy, and with an adequate psychological support, they status can really improve without any drugs and without any long-term consequences. So for the end, I would like to stress your attention and to mention that perinatal neurological complications represent a critical threat for maternal health. And the prothrombotic state and hemodynamic changes in the pregnancy are really core factors that can influence the development, or at least can precipitate the neurological disease in peripartum period. All obstetric neuropathies are avoidable, and the only thing is that we have to really look at the way how we provide care and how we help the ladies to deliver the baby. On the other hand, understanding of the spectrum of neurological disorders from vascular to functional is very crucial, because based on this understanding, we really can come up with an adequate treatment approach, and early recognition, interdisciplinary management can really help us to come up with the real true diagnosis and treatment. Thank you for your attention, and I will be more than happy to answer to your questions during the Q&A session.